Top Med Talk.
Monty Mythen here. As we prepare to move into the next phase of the COVID crisis, we're going to be widening our focus here on Top Med Talk. We will continue to deliver COVID-specific programs, but we all have a huge additional responsibility as we try to reboot normal services. So although this piece is not directly related to COVID-19, we believe it's information that is crucial to the bigger task of rebuilding the healthcare system as we learn to adapt and live with this new virus. Thank you to our sponsors and to you, our listeners, for helping us to share this important information.
Well, hello, I'm Desiree Chappell, and this is Top Med Talk. We are coming to you live from the American Association of Nurse Anesthetists 2019 Annual Congress in Chicago, Illinois. AANA 2019 is a gathering of over 3,000 certified registered nurse anesthetists, or CRNAs, for the largest networking and educational event in nurse anesthesia. This year, the AANA has partnered with Top Med Talk to bring the meeting to our listeners. Now, I'm joined by my co-host and editor-in-chief of Top Med Talk, Monty Mythen. Hello, Monty.
Hey, Desiree.
We're in the final stretch here.
I'm excited. It's that last interview. They've all been wonderful. We've had really great conversations.
Miss Lynn Reede, who is the now new title Associate Professor at Northeastern University in Boston. Hello, Lynn. How are you?
Hi, Desiree. Hi, Monty. So good to be with you. Thank you for all you do.
Well, Lynn, you are a wonderful friend of the Top Med Talk family and our family.
Yes,
for sure. Well, Lynn, we have had some amazing conversations here at the AANA this year and partnering with them to bring what CRNAs are doing within the association and really outside of the association. I think it's just important to highlight those things, and I think we have had that opportunity. But I always love to hear what you're doing, Lynn, because I think that you are like an ambassador for CRNAs and anesthesia in general in our community. And so tell us about some of the new things that you're working on these days.
So I just joined faculty at Northeastern University, excited to be back with the beginning of the profession and bringing them forward. And as we were discussing yesterday in our enhanced recovery track, just the opportunity to work with the students in each of the cohorts and really talk about enhanced recovery, what it is as far as practice, which they're seeing in their academic medical centers and some of the rotations in the Boston area, which I'm really excited about. But to talk about the value of data, which people aren't seeing. Mm-hmm. They're not seeing their outcomes or even their lead measures, and what are they doing to really contribute to the patient's improved outcome and engagement in their care. Though that being said, one of my colleagues, Mass General, just sent her data the day after we had that presentation. So I don't know if they heard me and thought they better send something out. But congratulations to them, because that's really how we continue to engage folks to improve the care they're providing, but also with the students talking about their opportunity going forward in leadership to implement, to become that full provider of enhanced recovery, not just in one element or two or three, but how can we drive that?
Can I come back to that in a second?
Yeah.
I'm not ducking that question, but I'm just sitting here realizing that we have a global audience listening.
Sure.
And we recognize the fact we're at the American Association of Nurse Anesthetists.
Yes.
And there's going to be a whole load of people out there who don't know what that means.
Okay.
Being a nurse anesthetist. Now, you're both nurse anesthetists.
Yes.
Anesthetists.
Sorry.
We like the E in there, too. We're honored to be at least included in that family.
Well, how do you, okay.
I'm just teasing. It's just because whenever I came here, I've been saying anesthetist for the last 6 months.
It's hard to go back and forth across the pond, yeah.
Nurse anesthetist. What's the story behind that? How long have nurse anesthetists been practicing in the USA?
Oh, my gosh. So it goes back to the Civil War is really where our history goes back to. But the evolution just had the opportunity to go to the Ether Dome at Mass General. And people came to watch the surgeons.
Yes.
And whoever was at the head of the table administered the anesthetic, and the patients didn't do so well.
Because the first anesthetic in England was given by a medical student. Mm-hmm. Because they just happened to be there. They said, we need someone to hold the sponge over the face or whatever it was, and say, can you come and do that?
Right.
But specifically, because you're working now at a nurse anesthetist
education program, sure.
So one of the tracks for somebody as a professional choice in life is they choose to train to be a nurse anesthetist.
Sure.
What's usually the route into that? They're usually a nurse first.
So yes, be a nurse anesthetist. So here in the United States, it's baccalaureate degree in nursing, several years, at least a year in critical care practice. We really feel that that decision making, that leadership in practice is so important to the foundation of our profession. The high touch, the high caring that we think we bring as nurses, and I'm pretty confident that's the truth.
Describe a journey to me. So
nurse, BSN,
and how long does that take?
Baccalaureate, 4 years.
4 years, yeah.
And then a year or two of critical care nursing. But we're seeing even more. Yeah, we're up to 6 years. Yep. And then 96 of our nurse anesthesia programs now are at the doctorate of nursing practice level. The remaining 25 are masters in nursing.
So how many more years is that?
So probably about another 3 years.
Okay, so we're up to 9 or 10 years.
Correct.
To be training.
Don't let me think about it. It seems so quick.
Well, I think that
is important,
It's
Monty.
an important perspective to be. So 9 or 10 years of training, and then depending on where you work in the USA, you can either you're an entirely independent practitioner or you're working in an environment where there's co-working.
Exactly.
Yeah. Care teams.
Yeah. Well, and before we do that, I would add that we take a certification exam.
Yep.
We're licensed to practice in all 50 states.
Yes.
Some states, 29 states, have prescriptive authority as well, but that's not necessary to administer anesthesia. But to your point, we work with anesthesiologists, though not required, but we're honored to do that.
Because there's a team game.
It's a team, yes.
Very much like critical care.
Exactly.
Forever in critical
Everybody
care.
bring their best.
Exactly. I mean, I work primarily in critical care, and it's a nurse-delivered specialty.
Exactly.
We go around making suggestions about care packages, but the work's all done by the nurses and helped along by the junior physicians. But most of the...
Well, and certainly the evolution we've seen in the country, too, that though there were cities that were metropolitan areas that were physician-centric and only anesthesiologists provide anesthetic, it's just not affordable. And so to increase, as we've all we're retiring, fewer anesthesiologists, nurse anesthetists, that everyone needs to provide care. So that's what's happening. We're seeing the demand for nurse anesthesia practice going up.
Yes.
And for our skill sets to go up. So related to regional anesthesia, sort of places that CRNAs weren't doing that at all, places where CRNAs weren't providing obstetric care, now they are. However, as to your point, in the military, we've been the prime provider independently, whether it's the battlefield coming back to Langstuhl and then distributed to the hospitals here. But in our rural sector, it's a lot of nurse anesthetists and majorly nurse anesthesia provide care. And what we're seeing is more and more collaborative care where the anesthesiologists sit down and provide anesthesia, the CRNAs sit down and provide anesthesia. Everybody's taking care of the patient.
I understand part of the reason of it all happening was crisis management. There was an unmet need. There were certain places where you couldn't get physician anesthesiologists. They weren't available to do the work that was required. And I think that's what happened in a lot of places in Europe, a lot of Scandinavian countries as well. It's kind of like, come on, those people need looking after here.
Yeah, in the late 1800s and early 1900s, really both specialties emerged. And the nurse anesthesia, probably even prior to the anesthesiologist, the physician anesthesiologist, and that's probably when the court battle started. But it was actually surgeons that brought nurse anesthetists forward.
So I don't want to get into it at all, but I referred to it earlier on. There's quite a lot of ugliness you can pick up on the Twitter sphere about physicians, nurses, whoever it is, name-calling each other.
It's kind of sad, isn't it?
Can we get a lid on that?
Yeah.
Can we go back to thinking about the patient?
That's it. Yeah. Right there.
So let's move on from that.
Yeah, deliver safe anesthesia.
But the bottom line, anesthesia is a practice of nursing and medicine, and we share the same standard of care, and we share the same patients, to your point. So I'm totally on that board as the ambassador.
As the ambassador.
The diplomat.
The ultimate diplomat.
So, the other work we're doing quite a bit is working with the Anesthesia Patient Safety Foundation. Yes. We're pretty excited about the Stolting Conference coming up, looking at patient deterioration. Really, we've been doing quite a lot of pre-work to look at across all folks who take care of patients in the perioperative space, what are those transitions of care and what are those challenges you're facing that put our patients at risk? And of course, communication comes to the top. We're seeing that bubble up pretty rapidly.
Yeah.
So back to your question, which I was ducking,
yes.
which is basically how do we get the enhanced recovery back? I think you need to get it back into school. It's in the ball's in your court now, Lynn. You need to make sure that the students only learn enhanced recovery principles.
That's why every time I see you, I have new responsibilities that I can't usurp, I can't escape.
You got to do. I know.
So that's why I always ask you, Monty, what is it I should be thinking about?
and then for all the anesthesia providers, there's a toolbox there, which goes from the different way you speak to people preoperatively and managing expectations, your attitude to the NPO window, and then you've got to be able to do the techniques. You've got to be able to do the regional, you've got to be able to do the multimodal, you've got to be able to do the hemodynamic management, the goal-directed fluid management. You've got to get them awake quickly, and you've got to let them drink, eat, mobilize.
Yeah, exactly.
And then you've got to say, and take ownership of when it doesn't go according to plan. Is a lot of the post-operative morbidity is because we had a bad day at the office, and you've got to understand that. Yeah,
that we get.
That's our value proposition. Is that we do make a difference.
Yeah.
Well, I want to get back to that because I think that there's a huge component of education. I think more discussion is needed. But so Lynn and I we worked on the enhanced recovery track for the meeting this year, and learned a lot about what we anticipated we thought the needs of the community would be, and then what we feel maybe the actual needs of the community. So from your perspective, what did you think about the enhanced recovery track this year?
Sadly, I was presenting another track, so I didn't get to attend that much, but when we were doing our planning, we were really responsive to what we've heard from our colleagues in the past, thinking that it was that implementation challenge, right?
Yeah.
And when what we're learning is it's also, not only, but also their individual skills, their ability to understand what enhanced recovery is.
Yep.
And people are really, they're still looking for that secret recipe, the secret sauce, and that's not it at all, is it?
No, there is no secret sauce.
There is no. There's
teamwork and
yes,
high levels of compliance. That's the secret sauce.
That's the secret sauce.
Yeah.
But they're still back at how much gabapentin, what block should I do for this and for that. So I think that we still need to scale our project, moving now from the AANA and the Shared Interest Group back into the American Society of Enhanced Recovery, our CRNA committee role there. But how can we collaborate with everyone across all the specialties to bring our specialty forward? So I think we're going to have to scale it from the folks who are down here just figuring out how to get on board, how to make a difference in their practice. As we heard from Carol yesterday, she really was asked to take this project on. She did it with the best of her ability, doing the evidence-based research, working collaboratively, and learning how, as you were pointing out, Monty, using Cotter's model, how to engage people across that continuum for continued success.
Yeah.
And then not all CRNAs have that access to that electronic medical record. So how can you do simply what you were talking with us last night about, Monty, simply looking at your data periodically, maybe it's not moment to moment, day to day, but take a snapshot. Where'd you move from your last snapshot? Is it what we're doing working? Do we need to eliminate an element, add an element, improve an element? Who's not participating in our team that should be? And are we asking our patient what matters?
Yeah.
That was an important message.
And that's I think the dream statistic is very tangible. So drink, eat, mobilize.
Yeah.
Now, even if you can't get to see your patients post-op, if you've got some method where you can get feedback, if as a provider 99% of your patients are drinking, eating, mobilizing after major surgery, then you've done a great job. Now, if 50% of them are, it might be that you didn't do such a good job, or it might be that no one's trying to get them out of bed and get them fed. But you kind of need to work on understanding that, because it might be you as the provider who's just giving the wrong type of anesthetic and the wrong type of fluid management, or it might be that no one's exploiting your great product. I served them up perfect, and nobody can be bothered to work on that.
It's a little red hen story, right?
It is, yeah, it's worth knowing. And it's somehow, we've got to try and get that information, because we all want to do a really good job. We're all very proud of doing a great job. But if we don't know what happens next.
But I really like the dream. It's so simple.
Yeah.
It's simple yet complex, but it's a great lead measure. Yeah. You're not just looking at the outcomes. You're looking at what's going to make the difference if you do these simple things.
Absolutely.
If you focus on those, you'll get to the good outcome, that the patient won't come back. They'll be properly hydrated. They'll be eating, drinking, mobilizing. You've addressed their discomfort so that they can manage it as they move through their recovery, but you've engaged the patient.
So I'd love the day where, and some people I think are there already, where the day after you've looked after somebody, you get a little text message that said, "I've just been for a walk and had breakfast, thank you."
Yeah.
You need to talk to Bob Vossberg from Survey Vitals. He would get you that.
Because that's the, as opposed to, I haven't had that message, I better find out what happens. Well, I've got my head down the big white telephone because I'm not feeling so good here, and the thought of breakfast. You familiar with the big white telephone?
I've never heard that before, but I get it.
Is that like the hotline?
Yeah.
No, what I really like about that is that it's where you go for customer service, but now we're really talking about, we're engaged together and simply pick up the phone and say, "Hey, what's happening?"
Yeah. Well, I mean, the dream thing, I love it. I mean, I've used it in my own personal practice and use it as a very easy communication tool with everyone in the space. So when you talk to your nurses, everyone instantly gets it. When you talk to your surgeons, everyone instantly gets it. You go up, is your patient drinking, eating, dreaming? Drinking, eating, and moving. And if they're not, then there's something wrong. Mm-hmm. And you go back to the nurse and say, why are they not drinking? Well, they've been throwing up all night long. So it's a communicative type of tool to use that's really easy, that it's really hard to screw up.
And maybe we need the poster. I'm so old, I'll say poster instead of infographic. That instead of just hand hygiene right beside that, or you're drinking and eating, mobilizing,
And then you can understand why they were throwing up. Some people are going to throw up no matter what you do. But was it because I gave them a whole load of opioids they didn't need and didn't give them the right antiemetics because I didn't risk rate them? Or is it I served them up having not seen an opioid and, 2:00 in the morning someone slugged them?
On an empty stomach, and now they're barfing their brains out.
Let's understand that.
That's why, that's how I educate people on how to use it, because people are like, oh, it's almost too simple. You don't get enough. I'm like, no, you actually get a lot. It's a opening statement and easy to track.
And barfing your brains out is the same as the big white telephone.
The big white telephone. I got it.
Yeah. Oh, God.
Okay, it's for our listeners. Sorry about that. We digress a little bit. Well, Lynn, what are some of the takeaways that you got from some of the enhanced recovery conversations you got to have over the weekend?
Well, I think I'll go back to the webinar that we did Wednesday night that was just the general overview of enhanced recovery and implementation. And I think that's where I really picked up. People are still back at that very basic, how do I provide multimodal pain management? It wasn't all the elements of enhanced recovery.
So this is my observation too.
Yeah.
So in anesthesia, particularly CRNAs, but in anesthesia in general, if they don't know a lot about enhanced recovery, they say, yes, when you ask them, I'm doing enhanced recovery, they'll put their hand up, but they're saying ERAS equals multimodal pain management or, opioid sparing analgesia or opioid free anesthesia. And those are not necessarily the same.
And maybe it's our responsibility too, from how we delivered the message, that many of the elements of enhanced recovery are anesthesia's responsibility.
Yeah.
And it's not just that we administer those elements, it's how we I think what got dropped was how we collaborate with the pre-anesthesia team, the surgeons or proceduralist's office, so that we can get the best information to them so they're not telling patients to be NPO.
Yeah.
And that the patients, and we found out yesterday too that medicine was telling patients not to drink their carbohydrate drink.
We've had dietary take trays out of people's hands because they were supposed to be NPO. So it's all that, it's that communication. With the team.
There's just so many pieces, and to create that comprehensive web. And the CRNAs, the anesthesiologists, the anesthesia professionals are in the perfect place to really provide that. And back to your point earlier, Monty, anesthetists, physician anesthesiologists, nurse anesthetists, even our anesthesiologist, well, probably not so. I'll skip that. We're prepared
Team
to
anesthesia.
We're prepared to take care of the patient across the continuum, but a lot of people are still parked in the operating room.
Yeah.
So you got to get out and meet your colleagues. You're not going to be able to do it all.
Right. You can't.
And that's the beauty of it.
Yeah.
So other takeaways. So, Desiree, you and I are talking and thinking about what we learned this year, and we really focused on the team.
Yeah, we did.
Julie Thacker was here, and I'm so sorry I missed my friend, but we had the surgeon here, we had the anesthetist, we had the nutritionist.
Enhanced recovery coordinators, nutritionists,
We had RNs, navigators. And also so several CRNAs presented the whole continuum of a CRNA implemented program. Mm-hmm. So we offered them that, but I'm wondering if people, I look forward to the eval so we can see what we didn't offer them and what we can do to build a little bit more comprehensive, not just live program here, but the resources necessary. Because the pokies are wonderful. Gosh, I use those constantly. the visuals.
The perioperative quality initiative.
Exactly. Yeah. We have a lot of great things out there, but how do we continue to get them into people's hands so they engage with them and integrate them into their own practice?
Yeah. So I think part of the challenge is team anesthesia all believing that what they do makes a bigger difference than the go to sleep and wake up bit. Mm-hmm. Whether that person develops complications post-operatively, we have a major influence on that. Whether it's the chest infection, the wound infection. People saying, well, what have I got to do with the wound infection? Well, you look at some of the big trials on fluid management. Yeah. You give too little or you give too much, you get more wound infections.
Exactly.
And why would that be? Because you're affecting the perfusion of the tissues and allowing bugs to get in, and so it goes on. So we have a big impact on that. And if you don't believe that, you're having a negative impact on your own value proposition.
Your head's in the sand.
Exactly. Yeah. We're reasonably expensive providers because what we do makes a huge difference.
Yes. Yeah. But I think, that kind of struck something. So, when we, some people do say they want more science. And maybe it's not just the science of this works, this is going to work, but the pathophysiology of, okay, this is why this makes a difference because...
Why would running someone dry give them a wound infection?
Right. And to go about it from that angle. Really the pathophysiology of recovery and then what we're doing to affect
when you
that.
Underperfuse the GI tract, the contents of your GI tract leak into your bloodstream. Think what's in your GI tract.
That's not a lovely... You've had so many lovely thoughts in this conversation.
Leak that into your bloodstream and then deliver that to your wound. It's not rocket science, is it?
No, it's not. And, hypotension and there's a million things that we...
The warming, the antibiotics, there's just...
Yeah, that's just for wound healing. That's not post-op nausea and vomiting. All these things that we don't see that we need to see, but understand the science of that. I think is huge.
Yeah.
Well, we need to integrate it into our thought.
Yeah.
It just needs to become who we are. To your point, we won't be talking about this in a few years, we hope, because it's just how we do business.
I hope so.
Would that be amazing?
Absolutely. Yeah. Well, that's what when we interviewed Henrik Kellett.
Mm-hmm.
Oh, yeah.
He was very much on about the pathophysiology.
He was, yeah. And then maybe he's seen it before we did. I don't know. You've been saying it for a while, and it's interesting because I have conversations with you all the time, so I kind of forget whenever I'm out to have those same conversations with other people. It's it's kind of weird, but I think for us to go forward, like you said, for programming and just education. So
it's not just how you do it; it's why you do it.
Why that makes a difference.
Yeah,
why it makes a difference.
That's where the buy-in is.
Why does running someone dry give them an ileus? Why does running someone dry give them persistent post-operative nausea and vomiting?
Yeah.
Once you get those images and you understand it, you think, oh, I get it now.
Yeah. It's not just about saying fluid restriction is bad because you cause acute kidney injury.
I'm not perfusing the lining of the GI tract, and when I do that, it decides to sacrifice itself. So it undergoes a process whereby it dies, and when it does that, it releases serotonin, for example. That tracks up your vagus into your vomiting center and makes you feel like, show me the big white barf your brains out. Is that right?
Yes, that's right. No, it's an interesting conversation. It really just provokes a lot of thought for me. About how we really get the information into the hands of the providers and get buy-in from, those people who are on the ground doing it every day.
I think from the AANA perspective, it's just trying to drive the value that you add to the care in your facility.
Yeah,
the importance of you.
Yeah. Yeah, it's true. Well,
you make a difference.
Yeah. And, we were talking about back to kind of what we originally were talking about in the podcast here was, becoming kind of premier, or what's the word I'm looking for? You're better with words than I am, but like an enhanced recovery provider.
Yeah, super provider.
Something that shows that you know how you can walk in tomorrow and do the things that you need to do.
So I think the multimodal analgesia is very attractive, but once you've written the recipe out, you can get pretty much anyone to give the recipe.
Yeah.
Mm-hmm.
When it comes to regional techniques, different skill sets, being very good and dexterous and choosing to give the regional block, if you can do a QL2, deciding how much to give, what to give. Mm-hmm. But then above that, the advanced hemodynamic management.
Yeah.
So if you can't do the advanced hemodynamic management, you're not a super provider.
Right. I totally agree. And then taking it a step further outside of the OR about understanding the principles of enhanced recovery to be able to work with your pre-op team. A lot of nurse anesthetists and anesthesia, we all do our pre-ops, to go out and be able to educate your patient and their family and to talk to your pre-op.
Yeah, but the production pressure is so huge. So that's why it's really important to work with the teams.
Absolutely.
To do that for you. But it won't be available until August of 2020. The new AANA continuing professional certification modules that we're required to complete every 4 years, we're building the enhanced recovery principles and concepts into that, including the patient-directed care. So I'm really excited about that. So all the profession will be brought forward. And so whether you're working in a GI center, there's principles here that apply across all the care that we provide, whether we're providing sedation or major anesthesia care. Yep. So I'm excited about that.
Yeah, I think that's great. ERAS for all. And then we have to
at least understand.
Yeah. Lynn, one of the other things that we were able to do this year to help spread the message was developing the AANA kind of resource at a glance enhanced recovery interop, kind of a protocol, and people do ask all the time, like, how much of something do you give? So we addressed a little bit of that on there. So
a little consensus work, a little evidence-based consensus work.
It was.
It's 1.5 pages, isn't it?
It's 1.5 pages. It's
very
easy.
Brief.
It's very brief.
Clear.
Yes, and you can literally take it in the OR and circle the things that you want to do and start tomorrow to do it.
Publicly available from AANA.com. It's not hidden. It's
on our resource
You don't have
page.
to be a member.
Yeah.
Anybody can have it.
It's just for interop, and it's so very, very basic, but at least it is a stepping stone, a starting point for people that are, wanting to, look at different multimodal pain, look at different fluid therapy, protocols.
Call a mentor.
Yes.
There's the CRNAs who are engaged in this are so willing to give it all away.
Absolutely.
Anything anyone needs.
Yeah. And everybody wants to share ideas. So we did a webinar last night as well. And that was just offered through the AANA, but hopefully we can, open that up as we go forward. But, we did kind of going over the interop kind of infographic, but in the hopes in the future that we're going to do just like Q&A and that we can just, have this expert panel. Because it was cool, just the expert panel sitting around talking about what we do in practice.
Yeah, we learn from each other every time we get together.
Absolutely, every time. And so opening that up, I think, will be a great resource.
So what are you going to do next year then? What will be different?
We were just talking before we all got on here together. Do we do a workshop that really we do the science, and then we do the how to integrate that science into your own practice and give people access to the folks who are doing it so they can kind of talk about what they already know how to do, maybe some one-on-one work. What do you know how to do? How do you garner that skills or the skill set you don't have or the resources? And then some of us that can help them talk about where's the power structure, where's the influence inside your organization so that you can start to look for those other folks who will come on the journey with you. Because you got to have the thought leaders.
Yeah,
I would think.
Those early adopters, you have to figure out those people who are enthusiastic about a lot of other things can usually be enthusiastic about.
Yeah. So it'll be interesting to see how the feedback comes back. But I think most of all, because we're making ourselves available year-round too versus just once a year, we continue to get that feedback. We can submit our abstract, but then we can continue to work with the professional development team at the AANA and see what we can do. Yeah. But also working through EBPOM or working through ACER or Enhanced Recovery After Surgery Society. There's so many places to collaborate
absolutely
and learn. And I don't know, Monty, what else have you seen? Well, we were talking about education. We were talking about entry into practice and how do we integrate this.
We've got to make sure all the schools just teach enhanced recovery principles, modern surgical care pathways.
Right.
it's been the new norm for a while now. So it's a bit disappointing when people say that when the new residents arrive, they have to go teach them about enhanced recovery. Surely that's what they learnt at school. Otherwise, at school, someone's spending a lot of time and money teaching them stuff we now know is the wrong stuff. That's not a good message. It could get me into a lot of trouble.
It could be. It's like, tread lightly there, though.
Well, but
it's true.
If the residents turn up and they have to be taught enhanced recovery principles, what's been going on?
Well, I mean, it's true.
The textbooks lag behind what's happening in practice often.
It is. Well, the fact that we're still using textbooks is kind of
interesting, isn't it?
But I mean, you got to have some of that there. But I think that, I mean, for me personally, I would love to start. Let's develop the curriculum for it. Just it's very easy. Like, here it is. Here's schools, start teaching that, because they are seeing that in coming back. But I mean, I'm still, every time I give a lecture on goal-directed fluid therapy and learning that we're still, learning things from the 60s. It's the antiquated way to learn fluid therapy. I mean, that's kind of scary. And that's not just in CRNA practice. That's in all anesthesia practice. And I mean, I'm sure, that crosses a specialty. So I think that, would be kind of good to start.
Yeah, I think the other thing that I've heard at the meeting, too, talking with our industry colleagues, create the monitors that are ubiquitous.
Yeah.
That aren't a huge expense to the case, but really let us monitor volume, status, responsiveness, all of that, so that it's like our pulse oximeter, our blood pressure cuff, our EKG, whatever, and we just know.
Yeah, that's true. Well, I think that probably should be a priority for us to work on this year. And Lynn, you're in a perfect position to do that.
The busier get busy, Desiree. I'm looking right back at two of them.
Yeah, a little bit. Well, as usual, Lynn, it's so lovely to talk with you and catch up.
It's a privilege to be a part of the family. I'm incredibly grateful to both of you for being the global ambassadors for improved outcomes, because having been a recipient and trying to create my own enhanced recovery pathway a few years ago, I can't tell you how lovely it would have been if that had just happened for me.
Yeah, it's true.
And I've heard that from many patients. Patients are the ones asking for their enhanced recovery, and folks aren't necessarily bringing it.
No, and it's gonna change.
Yeah, we'll get there.
We're working it.
It's a team effort all the way around.
Bring your patients. Well, thank you.
Yeah, thank you so much, and good luck in your endeavors this year. And I can't wait to catch up with you and hear how things are going.
Yes,
getting back in your hands dirty in the educational realm. Thanks so much for listening, and check us out next time. Cheers.
Top Med Talk.
Nick Majerison here. Thanks for downloading Top Med Talk. Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. EBPOM has been advocating perioperative medicine for many years now, using the traditional conference circuit, where people have attended meetings from all over the world and heard some of the latest information. However, in the face of the COVID crisis, EBPOM took a bold decision. We've transposed the entire conferencing experience into an online experience. Carbon-friendly conferencing. The latest information, the latest talks, the hottest experts, the most incisive analysis, and even the socialising. We've got it all covered as EBPOM goes virtual. Hot on the heels of the huge success of EBPOM 2020 live from London, we're now headed towards EBPOM Chicago. Come aboard and be part of one of the most exciting developments in medicine since the stethoscope. EBPOM Chicago. Get yourself to ebpom.org now and guarantee yourself a place at one of the most exciting conferences in the world.